Hello, everybody, and welcome to the first ERA Journal Club of 2024. So we're delighted to be kicking off this year's selection of Journal Club presentations with a paper selected from CKJ. So each ERA e-seminar is usually takes place on the last Thursday of the month at 1700 Central Eastern Time, which for us in Oxford, and there's three of us from Oxford today, is at 4 p.m. So each of the e-seminars is always picked from a topic that's been recently published as an original research article or a review article from either NDT or CKJ. And we have the author or authors come and present their work. And we have a selection of experts on the panel to help moderate the session and give us their expert opinions and feedback and thoughts and comments on the topic. So today's Journal Club will be moderated by myself, Parminder Judge, and Professor Will Herrington, and we're both Oxford-based nephrologists, clinical trialists, and kidney epidemiologists. And Will, many of you may recognise, was also the co-PI of the EMPA-Kidney trial, which I'm sure you're all very familiar with. So the discussion today will be focused and fairly informal, and we encourage live and hopefully very lively debate and questions from all the listeners, which can be typed into the Zoom Q&A box. And our expert panellists will help to answer some of the questions as they're coming in into the chat. As you can probably see, the meeting is going to be recorded, and all of the recordings are made available on the various video platforms afterwards. So keep an eye on the social media for links. So moving on to today's topic, we're delighted to have the topic of immune checkpoint inhibitors, which have seen a significant increase in the utilization in the treatment of advanced cancer over sort of following the initial approval for metastatic cancer. And the three main types that are broadly available, which act on sort of various different pathways, and we'll hear more about those from Professor Yang shortly. However, the three ICIs that have been associated with these increased risk of renal-related AEs, particularly ICI-related AKI, is sort of essentially acute interstitial nephritis, but also they've been shown to be associated with GNs and TMAs as well have been reported. Although the occurrence of all-cause AKI and ICI-related AKI and sort of rates of severe AKI and dialysis requiring AKI, and whether sort of the exposures to certain medications may increase that, are yet to be sort of fully confirmed. And we're delighted to have Dr. Hyang-Yu and colleagues on today's call who have investigated all of this a bit further and will hopefully provide some important insights. So as I mentioned, Professor Hyang-Yu is the senior author of the paper, and he's also professor of the Department of Nephrology at Changgung Memorial Hospital and director in the Department of Medical Research in the Changgung University School of Medicine. And Dr. Yang's research has focused mainly on metabolic cues such as HIF1 in lupus and renal transplantation, but his lab is also interested in microRNA and epigenetic regulation of the immune system to modulate renal disease. So we're really excited and delighted to have him present this paper today, which was published online back in November 2023. And we're really very grateful for Professor Yang and his colleagues for considering and bringing their work to CKJ and also to today's ERA Journal Club. In addition to Professor Yang, we're also extremely fortunate to have our two external panel members with us today. So I'm delighted to present Dr. Clara García-Carro from the University of Madrid, who's also published several papers on this particular topic, including recommendations of the Onco-Nephrology Working Group of the Spanish Society of Nephrology in November in CKJ, as well as another paper on last February on the role of AKI in patients with ICI. So lots more for you to go away and read about on this topic following today's presentation. And finally, I'm also delighted and very grateful to Professor David Moll, who is a colleague of ours from the University of Oxford and the Department of Nephrology in Oxford, whose group works on mechanisms by which cells sense and respond to reduced oxygen or hypoxia and their role in cancer development. So I hope you'll thank me in joining and sharing our presenter and our experts' knowledge and insights. So we have a stimulating topic and world-leading experts available, a live presentation and discussion. So please do take advantage and submit your questions into the live Q&A box, your questions will be answered. So Professor Yang, please do share your screen and start your presentation. We're really looking forward to hearing all about your paper.
Thank you, Professor Judge. It's my pleasure to present our recent research in the ERA Journal Club. We try to figure out the patient with immune checkpoint inhibitor leading to all-cause immune checkpoint inhibitor associated AKI, including their occurrence rate and risk factor, and this kind of meta-analysis study. And this is the disclosure of interest. Immune checkpoint nowadays has been used for a lot of tumor patients, and is a landmark treatment for cancer with increasing prescription recently. And the IRA, the immune-related adverse event, is become more and more noticed nowadays, and including AKI. An early cohort study found higher AKI than in the CRT. The AKI occurrence rate from RCT is less than 3%. However, in the retrospective study, the incidence rate is much higher. And PD-1 inhibitor use with poor AKI occurrence rate is 2.2% from early RCT. And from the real-world study recently, including 80 cohort study, they shows that all-cause AKI are about 60%, and they also analyze the risk factor for all-cause AKI, but not immune checkpoint-related AKI. And potential risk factor for all-cause AKI in patient with immune checkpoint are OH, CKD, combination of immune checkpoint regimen and intrarenal IRAE, and also PPI onset. And PPI onsets are associated with AKI or acute tuberous institution nephritis in general population. And the recent real-world study have shown that they also increase the risk of all-cause AKI. However, their relation with ICI-related AKI is still unknown. Why the PBI will lead to AKI? The possible mechanism in addition to direct toxicity, also people thinking about PBI may serve as a heptan. So when their modification form with heptan associates with the tuberous tissue protein presented by dendritic cell, that will lead to T cell activation. And especially in the tumor environment, initially the immune checkpoint is using to activate T cell, because initially when T cell want to kill tumor cell, T cell will secrete interferon gamma that will lead to PD-L1 expression on tumor cell. And PD-L1 will link to PD-1 on T cell. PD-1 and also CTLA-4 are co-inhibitor signal for T cell. So that the PD-L1 expression on tumor cell will inhibit T cell activation. So the immune checkpoint inhibitors such as anti-PD-1, anti-PD-L1, and anti-CTLA-4 is to block the co-inhibitory signal from PD-L1 or CTLA-4. And this kind of therapy, they may lead to IRAE because they not only activate tumor-specific T cell, but also can possibly activate the other cell, such as PPI Herrington related T cell activation. So the activation may lead to kidney injury and leads to injured kidney tissue produce inflammatory cytokine. So it will not only lead to subclinical AIN, but also such as TGF-beta may further progress the disease to AKI, CKD, and even ESKD. The knowledge gap is that the all-cause AKI and the ICI-related AKI from prospective study or retrospective study has not yet been systematically examined. And also, as I mentioned before, PPI and NSAIDs, they seem to associate with all-cause AKI, but their relation with ICI-related AKI is still unknown. And also, the PPI and NSAID as a risk factor of AKI. And how about the other potential bias, such as the publication bias or drug-drug interactions, such as concomitant exposure to PPI and NSAID are unknown. So our research tried to including update systemic review in PubMed, Medline, CNKI, and EMBASE. And the data has been updated even to October 2023. We including the occurrence rate of AKI from different definition and study reports all-cause AKI, ICI-related AKI with record of PPI and NSAID. And we also including the reports about the mortality rate of all-cause and ICI-related AKI versus non-AKI group. For the outcome, the acute kidney injury, usually the prospective study trial usually use CT-CAE criteria. And usually that is for a severe case of AKI, including hospitalization, life-threatening dialysis, and death. And retrospective cohort study mostly use KD-equal AKI and also acute. For the data analysis for the proportion of all-cause AKI, ICI-related AKI, and AKI occurrence rate, we use random effect model with the inverse variance method and use the restricted maximum likelihood method for between study variance. And we use the Houghton Knapp method for constructing the confidence interval. For further analyze the PPI NSAID exposure related to AKI development, the random effect model with Mantel Hansel method and the restricted maximum likelihood method for drug-drug interaction, and hardnet method for constructing confidence interval. And about the data synthesis and analysis for heterogeneity in current rate, we further doing the subgroup analysis, including the study design, the major malignancy, the different AKI definition, the study location, age, and sample size. And for the association between the drug exposure and AKI development, we use multivariant meta regression for drug-drug interaction, and use train and field methods for the propagation bias. The study totally including 120 studies. The total enrolled participants is 46,000, and the number of the retrospective cohort study is 42, and retrospective match is 4. And basically it is male predominant, and the major cancer type are lung cancer and melanoma. And usually the mixed cancer type was published retrospective, and also is single center. And multi-center usually is prospective trial and a single cancer. The all-cause AKI occurrence rate, totally 160 study with 44,000 patients. The all-cause AKI occurrence rate is 7.4. And because the retrospective study, including the relative milestone of AKI defined by Katigo Akin, so their occurrence rate is 14%, and the prospective study is about 1.2%. Further, let's see the subgroup analysis. The major cancer is melanoma and lung cancer. And we can see that AKI definition from the Katigo or Akin, the AKI occurrence rate is higher compared to the CT-CAE. The criteria usually used in the multi-center and the prospective trial. So you can see the multi-center trial and the CT-CAE criteria. The occurrence rate of AKI is low. Usually the single center is retrospective and using Katigo and Akin criteria, so you can see the occurrence rate is much higher. And for the sample size, the largest sample size usually is retrospective, so you can see. Also, they showing the higher occurrence rate. About the occurrence rate of ICI-related AKI, most of the study, they usually are defined by nephrologist or oncologist. And nowadays, the ICI-related AKI did not have a defined criteria. And some study try to use predefined criteria. The defined ICI-AKI use biopsy confirmed, and probable AKI should meet these 3 criteria, including creatinine 1.5 above baseline, or absent of an alternative plausible cause, or at least have some criteria showing they are tuber institutional nephritics, or they have concomitant non-kidney IRAE. And the possible ICI-AKI, they have alternative etiology not readily attributable. The subgroup analysis of ICI-related AKI, totally 25 retrospective studies are included with 21,000 patients. And ICI-related AKI occurrence rate is 3.2, and they have high heterogeneity. And this slide shows the PBI and onset for all-cause AKI. The PBI exposure have 77% increase for all-cause AKI. And the meta regression to analyze the drug-drug interaction still show the odds ratio of 1.74. And TF method to including the publication bias still show high odds ratio, about 1.48 for PPI exposure for all-cause AKI. And NSAID exposure for all-cause AKI, their odds ratio is the same as PPI, then still show the increased odds ratio after consider about the drug-drug interaction and publication bias. And for the PPI and onset for ICI-related AKI, the PPI exposure, their odds ratio is 2.42. The onset odds ratio is 2.57. And consider about the drug-drug interaction and also publication bias still show the increased odds ratio for ICI-related AKI. So our strength is this the most updated systemic review and meta-analysis. And we analyze exposure to NSAID and PPI and the development for not only all-cause, but also ICI-related AKI. And the sensitivity analysis for drug exposure and AKI development, including the drug-drug interaction and propagation bias are included in this study. The limitation is that for clinical trials, some article may not be identified from our research. And another thing is that for clinical trial, usually use CTCAE-based criteria. And because they usually apply the patient at least hospitalization. So usually the result will underestimate the true AKI. So we can find the prospective study shows the lower rate of AKI. And because this study, we including different kind of studies, so definitely is high heterogeneity, and including some major confounder. And another problem is that nowadays, we still did not have universal accepted criteria for immune checkpoint related AKI. And the long-term kidney outcome of AKI usually is not including in the published data. So for the take-home message, maybe we can see the graphic abstract. So this is the most updated meta-analysis. So we analyzed the cancer patient on immune checkpoint with the outcome of AKI, and immune checkpoint related AKI, and their relation with exposure to NSAID and PPI. And also mortality of AKI versus non-AKI was included. So from 122 study updated to October 2023, the occurrence rate of all-cause AKI is 7.4, and about 14% for retrospective study and 1.2% for prospective clinical trial. And occurrence rate of immune checkpoint related AKI is 3.2. And both PPI and NSAID, they disclose the increased odds ratio for all-cause AKI and immune checkpoint related AKI. So this is the presentation today. I would like to take any question. Thank you.
Thank you very much, Professor Yang, for an enlightening and a very detailed presentation on ICI and AKI rates. So I can see that there was a question in the chat, which Dr. Garcia has very kindly already tried to sort of provide some insights into. I'll open it up to our expert panel members and see whether they have any questions or comments that they'd like to make. There are a couple of questions that were received in advance, but before we go to those, Professor Mole, Dr. García-Carro.
You want to go first, or would you like me to go first?
You can go first.
Okay. Well, first of all, I'd like to thank you very much for a lovely study. This is clearly a really important question. Immune checkpoint inhibitors are a very rapidly growing class of drug, and I think the use is predicted to treble over the next few years to a global market of about 45 billion. And they're being used across a wide range of cancers. I note that your study mainly focused on lung melanoma, renal and urothelial, but I noticed that the studies were drawn across 18 different types of cancer, and these drugs are being used extensively in treating metastatic cancers, but also increasingly now as adjuvant treatments for surgically resected cancers in earlier stage in the pathway. So it's really useful to know the rates of renal failure when we're counseling patients as to their use, when we're trying to decide between different treatments and when it comes to health economics. I think PPIs are also an important issue as well. Many patients will be on a PPI going on to treatment, but also if patients do get acute interstitial nephritis from their immune checkpoint inhibitor, they often get treated with steroids and will be put on prophylactic gastric protection, and just raises the question of whether we should really be using H2 receptor antagonists, although they have a lot of bad publicity rather than the PPI. And I think it's also important because although the bad effects of non-steroidals are well recognized in non-nephrological community, the bad effects of PPIs are less well recognized. There's a number of questions I have. There's clearly quite a lot of confounding factors going on here because the rates of renal failure do vary quite a lot across the studies. And I think you've highlighted one of those, which is your definition of acute kidney injury. And I suspect between prospective and retrospective, there's also patient selection. Prospective studies are probably selecting fitter patients than all patients in a retrospective study. But you mentioned that the immune checkpoint inhibitor rates of AKI are about 3.5, 3.2%, whereas globally it's all-cause is at 7.4%. But that all-cause is across both retrospective and prospective. And the immune checkpoint inhibitor, I don't know whether that's predominantly retrospective studies or whether it's predominantly prospective studies, because it then makes a difference as to what proportion of patients getting AKI have it related to the immune checkpoint inhibitor and what proportion are other causes. And I don't know if you might comment on that.
Yes. Yes. For the all-cause AKI and the immune checkpoint related AKI, their study group are not the same, because some of the published study only report all-cause AKI, and some reports both all-cause and immune checkpoint, and some only report immune checkpoint. So we try to gather all the study for all-cause AKI to show the meta-analysis study. So basically, they are different. For the immune checkpoint related AKI, I think a lot of study from the retrospective study.
So the comparator there might be the 14% that you're seeing in. So you're looking probably at about 1 in 4 patients with acute kidney injury, it being directly attributed to the ICI in terms of an interstitial nephritis, and about 3/4 may be other causes. So
yes.
It does raise the importance there of trying to make a diagnosis in those patients when you come to treatment.
Because for the all-cause AKI, they may be sepsis or volume depletion or the other cause that lead to the AKI.
Yeah. Another question I had in terms of trying to decide on treatments, I don't know whether you've done any subgroup analysis looking at the different classes of immune checkpoint inhibitors to find out whether one is higher risk than the other, or indeed in those studies where they're combining 2 immune checkpoint inhibitors, which we certainly do in renal. So we have a CTLA-4 and a PD-L1 inhibitor combined.
Yes. This is a very good question. However, according to the published data, we did not have enough information to answer this kind of question. But according to the mechanism, because the PD-1 initially the PD-1 and PDO anti-PD-1 and PD-L1 has been implemented in for the immune study. Initially, that's because their side effect seems to be lower as compared with the CTLA-4 inhibitor. Because CTLA-4 usually will deplete the regulatory T cell. So I suppose that maybe CTLA-4 will have high chance for AKI, but we still need more information to answer the question.
Yeah, and again, it's going to be difficult because some of the treatments, it's a CTLA-4 for induction, and then PD-1 as the
yes.
So
yes.
it makes the
yeah, you're right. You're right.
So that's another one. I was interested as well that the dialysis rates were quite low in the ICI associated. It's probably about 1 in 2,000 patients actually require dialysis. I don't know if you had any idea of what portion of those patients would get off dialysis and have at least partial recovery of renal function. You know, typically we think with interstitial nephritis, even on dialysis, the recovery rates are pretty good, and the long-term consequences may be that they have some renal impairment, but they're off dialysis again.
Actually, according to the available data that we get, we did not know the final long-term outcome. But I totally agree with you that the tuberous institutional nephritis from drug usually can be improved if we stopping the drug and also use some immune modulation, including steroid. So I suppose that even though it goes into hemodialysis, and we stopping the immune checkpoint with a good supportive care, I suppose most of the patient can get recovered.
Yeah, and I guess another, probably my last question or last point is that often there's a lot of pressure from our oncology colleagues that once a patient's recovered from AKI, whether they can restart the immune checkpoint inhibitor. And as a nephrologist, that's something I feel very uncomfortable with, because you start the same drug, you're going to get the same answer. But I don't know whether there's any evidence on that, on reintroduction after the recovery.
Yeah. I think that first, I would like to stress on this study is that we find that the PBI and NSAID will increase the risk of both all-cause immune checkpoint study. So, for example, I once faced a patient, they use NSAID that leading to the AKI. And if we suggest them to stop the medication, then just for steroid treatment for 1 to 2 weeks, the kidney function become better. Then if we reinitiate the immune checkpoint inhibitor, we did not see the AKI again. So I think it's very important that we should try to decrease using those medication that will increase the immune checkpoint.
That's very helpful. Okay. I don't know, do you have any points or questions?
Hi.
Hi.
Oh, does it work? Yes, it works. Okay. So thank you very much for your presentation. I think that is an incredible article, and I think it's this kind of meta-analysis are very important to establish the real incidence of this kind of AKI. So I have 2 questions. I think we have some time. So why do you think these patients that are on immunotherapy and present AKI have higher rates of mortality than patients that don't present AKI? Because if we look at AKI itself, AKI normally it's a mild AKI with very good response to steroids, as you were mentioned. So that's my first question, and let's see if we have time for another one.
Okay, thank you so much. For the mild case of AKI, it should be fine. It will not influence the mortality. But the late stage of AKI, especially that goes into the dialysis, that definitely will increase the mortality. So I think that depends on the severity. And if we gather all the meta-analysis, we still find the immune checkpoint related all cause of AKI will increase the mortality rate. And
Okay.
and also that may be not related to immune checkpoint. That may be related to sepsis or the other events that lead to the AKI. Yeah.
Yes, because as Dr. Moore was saying a while before, I think that nephrologists don't feel very comfortable just re-challenging the immunotherapy drugs. So what I think, but it's my opinion, I think there are not a very big data about that, is that we have the tendency, or almost in the past, we used to have the tendency to stop immunotherapy and then the patient die, but it's not because the AKI, it's because of the cancer itself. But I don't know if you have data about that.
Sorry, I did not have data about that. For the response of immune checkpoint inhibitor, some people may raise that if you have some AE, you maybe have better response to immune checkpoint inhibitor, and most evidence is such as thyroiditis. But about AKI, I don't think that nowadays we have evidence. For example, like the patient have AKI, so you will have better response to immune checkpoint, so you will cure the cancer better. I don't think right now we have that. Maybe we can get more and more data to see if that is right for for kidney.
Okay, so thank you very much. And the other thing I want to ask is if you have some data about another risk factors for AKI in patients under immunotherapy. Do you know if a previous CKD is a risk factor, or have you analyzed it in your meta-analysis?
No.
No,
So
I was mainly...
it seems that majorly because some of the data when we do the analyze we will including the risk factor that including in most of the database. So if the data is not enough, we did not get the result.
Okay, I was answering that because nowadays patients with more comorbidities are being included in also randomized control trials, and also are treated with immunotherapy. So more patients with diabetes and also hypertension and a lot of comorbidities will be treated with these drugs. And I think it's interesting to know that kind of things. I don't know if Dr. Moll has experience with that or anyone.
The other medication that will associate with the higher risk. Is this you want to ask?
No. I was just commenting that
Okay.
more patients with comorbidities such as diabetes and also hypertension and that kind of things will be treated with immunotherapy. So it's important for us, the nephrologists, to know if previous CKD that is a risk factor for AKI. I think it is. In our study, we observed that result, but there are not so many studies saying that, and that was why I was asking this question.
Yeah, I totally agree with you. Although I did not have this kind of result, I totally agree with you that CKD have a higher possibility as a risk factor for AKI in using immune checkpoint inhibitor.
In that respect, I was a little interested in the fact that in your subgroup analysis, the renal cancer patients had a lower instance of AKI. And of course, a lot of those will have had a nephrectomy. So by definition, will have impaired renal function before starting. So you might expect them to have a higher incidence of AKI. So I was just interested if it was actually lower. We've had a question as well about using immune checkpoint inhibitors in transplant patients. And I guess this goes for patients with pre-existing autoimmune disease as well. And that's a very tricky question. I think the things to bear in mind that immune checkpoint inhibitors are frequently not curative, they're palliative treatments, and that not all patients will respond to immune checkpoint inhibitors. On the transplant side, it's very difficult to assess the rejection rates because the series that have been published have been very small, single-digit numbers of patients. But they seem to vary from around 30 to 90%, averaging around about 50%. So there's about a 50% risk of rejection, and that's often quite early, only a couple of weeks after starting the immune checkpoint inhibitor. And so the patients I've had, when we've counseled them about this, most of them elect to stick with a transplant rather than going back onto dialysis. A lot of transplant patients, having experienced dialysis before transplantation, will do whatever they can to stay off dialysis. But I think you have to take it on a case by case. You have to counsel the patient, but I think the majority will not want to take an immune checkpoint inhibitor.
Will, you have your hand up.
So just a question, really. I have patients with a variety of presentations with these types of agents. Now, our oncology colleagues will be the ones monitoring them rather than nephrologists. We'll be sent the patients when they notice catastrophic AKI. Is there something that the oncologists should be monitoring? Is there something that preludes acute kidney injury at all in the history? Tyrosine kinase inhibitors often, there's an associated hypertension. There might be some proteinuria before you might get changes in kidney function. Is there anything that might warn us? In this case, it looks like it might be difficult to look for preluding factors for ICI-related AKI.
Yeah, and I don't know, and it's a question of how you define ICI-related. I think most of us are using it to define interstitial nephritis, but of course they can get a very severe colitis and get dehydrated and AKI from that. I don't think there's nothing that I've come across really that will predict, other than anecdotally seeing them develop another autoimmune complication in the weeks or months preceding the AKI, and endocrine complications, hypothyroid, diabetes, hypoadrenalism, anecdotally seems to precede AKI sometimes. So it may be a warning that your immune system is losing tolerance and you're starting to develop problems.
And I think there are other presentations as well other than AKI. I mean, personal experience of quite florid acute nephrotic syndrome.
So the renal complications, there are some glomerulonephritides that have been described. They're much rarer than the interstitial nephritis, and sometimes it's difficult to know whether that is the treatment or whether it's the cancer. And we've got a difficult renal cancer patient who developed membranous nephropathy at presentation with renal cancer that resolved on nephrectomy, and now she's got recurrent disease. And do we treat her with an immune checkpoint inhibitor? Whether that will reactivate her membranous or not, I don't know. There's no evidence.
I just noticed as well there was a question about SGLT2 inhibitors that obviously caught my eye.
Yeah.
I mean, and the answer is we don't have the data, other than the fact that we need to start thinking about SGLT2 inhibitors being a potential effective treatment at reducing acute kidney injury risk. We see about a quartering of risk in the trials. The only data I know looking at medication use, I saw Clara highlighted a case series, is the DAPA-CKD did publish about acute changes in creatinine. They only had about 150 cases, but they tried to subdivide them into medication-associated AKI, pre-renal AKI, etc. And it was consistent across all of them. In fact, if anything, the medication-associated AKIs looked to be remarkably lower in those allocated to tipagliflozin. So within the realms of very small numbers studied, that would suggest that SGLT2 inhibitors, if you're on them, could be continued. I don't think they really should be considered as preventative measures yet for AKI, but I'd love to see someone do those types of trials.
Great, thanks, Phil. I think there's just a couple of other comments that have popped into the chat, which we could do very quick fire sort of answers on, because I am conscious of time we have overrun, but we seem to have an impressive amount of participants still on the call, which I think just reflects the amount of interest and in this topic. So the first question is there any way, I think we've sort of gone around this already, any way that we might be able to avoid this type of AKI? The next one is, are there any particular sort of novel, and it was a question that came sort of prior to the call as well, any type of novel markers that might be indicators of sort of AKI associated with ICI? There's the sort of in the chat it says particularly CRP or urine retinol binding protein. I mean, clearly, apart from CRP, some of these are going to be research type markers that we're not really going to be using in routine practice. One specifically for Clara from Will, in fact, if you could comment on sort of what your experience is with recurrence on re-challenge. I think that goes back to one of the questions that you answered earlier about sort of whether we should re-challenge or not. So I'll hand over to the panel to take us through those questions.
Okay, so first of all, biomarkers, I think they are very interesting, and they will be here soon. I think Dr. Herman from Mayo Clinic has a lot of experience with C-reactive protein and also with urine retinol. So I think they are good biomarkers. There are also some publications about urinary TNF alpha that it's also that could differentiate from acute kidney injury from other causes and immunotech checkpoint inhibitors related nephritis. And there are some things in biopsies with memory T cells, but they are not biomarkers, are histologic markers. So if we perform the kidney biopsy, it's easy to diagnose. And the other one, in my experience with rechallenge, I think it's very important to rechallenge because the patient survival depends on that. So I do rechallenge always with the oncologist working very close, and I think it's important to rechallenge when kidney function is okay, when AKI is finished, and I think it's not necessary to rechallenge with under high doses of steroids. I think we can rechallenge when the patient is maybe on 5 milligrams per day of prednisone or 10 milligrams per day of prednisone, because some years ago we used to increase steroids dose when we were starting the rechallenge, and I think it is not necessary. But there are no data, no published data about that, so we need to do more studies.
Okay, fantastic. So final comments from you at all, Professor Mole or Professor Yang? No, great. Well, clearly by the amount of questions and interest from the audience and from our external panel members, this was clearly a very important and a sort of worthy topic for debate. So I apologise that we've run quite a bit over, but I think it's been sort of well received given by the number of people that are still on the call, even sort of at this time. So I think given that we have run over, I think it's time to call time on our e-seminar. But from myself, my co-moderator, Professor Herrington, and on behalf of the whole of the ERA Journal Club team, we'd like to give our huge thanks to Professor Yang for publishing this paper with CKJ and for presenting this journal club, and also to Dr. García-Carro and Professor Mole for taking the time this afternoon to give us their expert opinion, which has been hugely fruitful in encouraging important discussion and debate. So please do go to the CKJ website and read the paper for anyone that hasn't yet read it, but also do check out the sort of related papers in CKJ and NDT, of which there are many, and I mentioned some of those, particularly from Dr. García-Carro, even sort of in November. And as always, please do remember to go and answer the survey with Zoom, which will appear shortly. And we do obviously appreciate your and value your feedback, which helps to keep these e-seminars running and sort of help to us to improve the format and sort of the type of topics that you might be interested in hearing. So if there are any comments, please do let us know. But for now, it's definitely a good time to say goodbye from the panel, the team at the ERA, Will and myself, and a huge thanks once again to all our speakers and moderators.